Welcome to our comprehensive review on spinal epidural abscess. We'll explore pathogenesis, diagnosis, microbiologic factors, and modern management strategies. We will review an article in New England Journal of Medicine from April 2026. A spinal epidural abscess is an infection in the epidural space, located between the dura mater and the vertebral column. Despite advances since 1948, diagnostic errors are common, impacting neurologic outcomes. Prompt recognition and multidisciplinary management are crucial. The epidural space's size and characteristics vary by vertebral level, affecting clinical manifestations. Sorry about the graphic. It's obvious that AI isn't very smart for graphics. Yet. The patient has his head rotated 180 degrees. Spinal epidural abscess progresses through 4 phases. Phase 1 involves localized back or neck pain, affecting over 80% of patients. Phase 2 presents radicular symptoms along dermatomes. Phase 3 includes early neurologic changes like muscle weakness and sensory deficits, seen in 20.47% of cases. Phase 4 results in paralysis, occurring in approximately 3.9% of patients. Complex back or neck pain occurs in over 80% of patients. Neurologic symptoms often appear less than a week before diagnosis, with motor or sensory deficits more common than bowel or bladder issues. Fever is present in 24.62% of cases and sepsis in 25.35%. Maintain high suspicion even without the classic triad. The lumbar and lumbosacral spine accounts for about 50% of spinal epidural abscess cases, with thoracic at 30–40% and cervical at 10–20%. Infections often span multiple vertebral levels. Neurologic risk is highest in the cervical and thoracic spine due to spinal cord presence and reduced canal volume. Ventral abscesses are common, often with vertebral osteomyelitis. The incidence of SEA has increased 5 to 8 times, now affecting 5.1 to 8.0 per 10,000 admissions. It predominantly affects men aged 50 to 65. Key risk factors include injection drug use, alcohol abuse, and obesity. Injection drug users are often younger and have a higher prevalence of viral hepatitis. For diagnosing spinal epidural abscess, erythrocyte sedimentation rate and C-reactive protein are key inflammatory markers, with C-reactive protein at 100 milligrams per liter and erythrocyte sedimentation rate at 60 millimeters per hour being common. Magnetic resonance imaging with gadolinium is the gold standard, distinguishing spinal epidural abscess from other abscesses. Positron emission tomography computed tomography or intravenous contrast computed tomography are alternatives but less effective. Urgent magnetic resonance imaging is guided by specific algorithms, especially with new neurologic deficits or elevated markers. Accurate microbiologic diagnosis is crucial for targeted therapy. Obtain blood cultures before administering antimicrobials, as bloodstream infection is present in 26.71% of cases. If non-diagnostic, consider image-guided aspiration. During surgery, collect multiple samples for culture and molecular diagnostics. Tailor cultures for tuberculosis, brucellosis, and mycoses based on exposure history, especially in immunocompromised patients. Gram-positive cocci, particularly Staphylococcus aureus, dominate spinal epidural abscesses, SEA. Methicillin-resistant Staphylococcus aureus, MRSA, is a significant predictor of non-operative treatment failure. Up to 15% of cases have no identified pathogen, often due to prior antimicrobial therapy. Polymicrobial infections are linked to aerodigestive tract proximity or lumbosacral surgery. Effective management of spinal epidural abscess requires a multidisciplinary team, including a general medical provider, spine surgeon, and infectious disease specialist. Rapid decision-making is crucial, with surgery ideally within 48 to 72 hours of symptom onset to maximize neurologic recovery. Treatment aims to restore function, control infection, and prevent complications through personalized, evidence-based care. Surgical management is crucial for new or worsening neurologic deficits, ongoing sepsis, spinal instability, or existing spinal instrumentation. Surgery should be urgent, with antibiotics started after blood cultures. The approach is tailored to patient health, neurologic severity, abscess location, vertebral level, spinal stability, and contiguous infection. Non-operative management fails in about 28% of cases, often leading to delayed surgery with poorer outcomes. Key risk factors include age over 65, diabetes, bloodstream infections, methicillin-resistant Staphylococcus aureus, high C-reactive protein or white blood cell count, serious neurologic deficits, and active cancer. Image-guided aspiration may help reduce bacterial burden in select cases, but requires expertise and lacks routine recommendation data. For antimicrobial therapy, start with empirical intravenous therapy using vancomycin and ceftriaxone. Adjust to pathogen-directed therapy based on susceptibility data, following Infectious Diseases Society of America guidelines. Treatment typically lasts 6 to 8 weeks, tailored to clinical response. Consider oral step-down therapy for patients responding well to initial treatment. Monitor neurologic status closely during therapy. Counsel patients to report symptom changes. Address modifiable risk factors like diabetes and obesity. Use serial erythrocyte sedimentation rate and C-reactive protein measurements over routine magnetic resonance imaging unless clinical status worsens. End-of-therapy magnetic resonance imaging is selective. For instrumented fusion, continue suppressive therapy until fusion is confirmed. In-hospital mortality ranges from 3.6%, with a 90-day mortality risk of 6.13%. Early surgical intervention leads to an 86% chance of good neurologic outcomes, compared to 69% with non-operative treatment. Surgery within 48 to 72 hours of symptom onset is crucial for recovery. Neurologic status at therapy initiation is the strongest outcome predictor. This decision framework outlines when to choose surgical versus non-operative management. For non-operative PADs, start with a biopsy, then antibiotics if no risks are present. High-risk features like sepsis or instability necessitate emergency surgery. Always assess neurologic deficits. Individualized treatment with spine and infectious disease specialists ensures optimal outcomes. High clinical suspicion is crucial, as the classic triad appears in less than 20% of cases. Multidisciplinary management is essential for improved outcomes. Accurate microbiologic diagnosis is key, with Staphylococcus aureus causing over 50% of infections. Future research should focus on refining diagnostic algorithms and standardizing outcome reporting.